Okay, next, Dr. Simar Ranjan Singh. Okay, he'll be presenting on multimodal imaging characteristics and genetic profile of achromatopsia in a North Indian cohort.
Thank you so much, sir. So I'll be presenting on achromatopsia. Achromatopsia is a relatively rare genetic disorder which is caused due to total loss of cone function in the retina. Traditionally, it has been described as a stationary disorder with a reported prevalence of about 1 in 30,000. It is a genetic disorder with 6 genes that have been described to cause it, out of which CNG-A3 and the CNG-B3, which are the cyclic nucleotide channel gated channel genes which guard that channel, are the most common causes. They cause up to 90% of the cases. And the Western literature reports CNG-B3 as the most common cause, while the Middle East and China report CNG-A3. And there is absolutely no data from achromatopsia from India, and it is an underdiagnosed cause of childhood blindness in India. So the purpose of our study was to describe the clinical features, multimodal imaging characteristics, genetic profile of patients of achromatopsia in a North Indian cohort. It was a cross-sectional analysis of genetically proven achromatopsia patients presenting to our retinal dystrophy service from July 2021 to December 2022. Diagnosis was based on the correlation of presenting complaints, clinical examination, visual acuity, color vision, and fundus examination, multimodal imaging including color fundus photograph, fundus autofluorescence, and swept source OCT, full field electroretinogram, and genetic testing, which included clinical exome followed by confirmation with Sanger sequencing. This was the case which actually developed our interest, first of all, and was seen that came to us at the age of 3 months, brought by parents with complaints of child unable to open the eyes in when the child was taken outside, and nystagmus. And that time a lot of investigations were done, queries, cortical visual impairment, nothing could be found at that time. Posterior segment also seen reported normal. Seen at 1 year, the nystagmus was decreasing, but still no diagnosis. 3 years, again the same. Cardiff visual acuity was about 624 and 660 in both the eyes. And the nystagmus was continuously decreasing. It was at 4 years of age when we actually saw the child in the dystrophy clinic. Child complained of photophobia himself, and color vision could also be recorded at that time when the child could only read the demo plates in both the eyes. So these are the videos of the child, and you can see very what we call as hamarlopia or day blindness, severely sensitive to bright light. And the upper video is actually not showing here properly, which shows the nystagmus that was present in the child. So coming on to the imaging of this child, this is the wide field optos photograph, which once you would see with an indirect, it is essentially looks normal. And even if you see it closely zoomed up into the posterior pole, it looks normal. You won't find any pathology. But once you do an autofluorescence on this patient, you can recognize this hyper autofluorescent ring that is just surrounding the fovea in both the eyes. So this was a definite clue that something is going on. And if you look at the OCT scans, which we could do, which are difficult to do in these children due to nystagmus, but you can see that optically empty zone at the posterior pole, which signifies that there are some photoreceptors that are missing. Electrophysiology helps you tell which photoreceptors are involved. Dark adapted, dim flash, and bright flash both showed good waveforms, signals coming, while the light adapted waveforms were almost flat, which signified that the cone system was not functioning in the child. The genetics confirmed our diagnosis with a compound heterozygous pathogenic mutation of a CNG-B3 gene, which was further confirmed with Sanger sequencing and parental segregation. So overall, our results, we had 22. Since then, we have had 22 patients, 44 eyes of genetically proven achromatopsia, 13 females, 9 males, 3 pairs of siblings. Average age of presentation is around 7 to 8 years, with the youngest child that we have diagnosed is now 3 months of age. And the average age at diagnosis initially was larger because we were not picking up these children, but now since we have started recognizing the signs, we are picking them up early when they come to us. Majority of the draining area was from our surrounding centers in PGI, Chandigarh, Punjab, Haryana, Punjab contributing the most. Hemarlopia and nystagmus were the most common features. Low vision was not a feature, but day blindness, child not opening the eyes in bright light, and nystagmus. And majority of the children, 18 children whom we could record visual acuity by various methods, had moderate visual loss. The genetic profile was completely reversed to what the West has reported, with majority 86 presenting with a CNG A3 mutation compared to CNG B3 that has been reported. So that was a major difference. So you can see the fundus, variable fundus changes from a very normal looking fundus to some amount of hyperpigmentation at the posterior pole and a frank atrophy. So 50% of the eyes had fundus changes, and autofluorescence could pick up more changes, and 83% of the eye has autofluorescence changes, which could be simple as some hyperautofluorescence, a ring of hyperautofluorescence, or complete hypoautofluorescence. The OCT had a very characteristic stage-like manner, and you can see these ages that I have put up of the children. So the first stage, there was just a small defect and flattening of the ellipsoid zone. The next stage, there was a proper gap that could be seen in the outer cone photoreceptors. The third stage, there was an optically empty space. The gap was widened. The fourth, 4A, you could see some RP atrophy and hypertransmission. 4B, that gap flattened down, the layers sat down. And stage 5, there was complete atrophy. And this was progressive as the age of the children was increasing, as is evident here. But the visual acuity was not. Visual acuity was similar in all these children. The treatment that we gave mostly was refractive correction, tinted or contact glasses or contact lenses, and counseling. The future does hold good things for us, as there are at least 5 clinical trials that are going on, with 3 of them now getting published, also reporting data that as to some efficacy and at least the safety of these. So early onset nystagmus getting better with age and hemarlopia may be the first signs of achromatopsia. We need to keep a high index of suspicion and look out for these signs and order relevant imaging, electrophysiology, and genetic testing. Fundus imaging, multimodal imaging, all of them combined together give us the best chance to pick up these children. And preserved cones in the initial stages, as shown on OCT, could be a predictor of better targets for gene therapy, which is just on the horizon, and we need more data for that from our country to go forward. Thank you.
Saying we need all the 3 combinations. Suppose we don't have autofluorescence, can we pick up with this too, OCT?
Absolutely, ma'am, because they are very uncooperative children. They are very hemarlopic. They are very resistant to bright light. So examination is difficult. Optos help, since it's a laser light. The flash is less. The child cooperates more. So zooming up on that, I have started picking up that hyperpigmented ring over there in these children and started seeing on examination also now. But that has come with some experience. Earlier, we used to just label them as normal fundus and nothing in the fundus. So they were just going round and round in the pediatric ophthalmology clinic, undiagnosed, getting multiple investigations, MRIs. But when we combine the 3 modalities, at least one of them would give us a clue as to something is abnormal. The OCT sometimes may not pass through exactly that, but repeating that maybe after 3 to 6 months, sometimes you will get that clue. And then you can proceed with further electrophysiology and genetic testing based on that.
But I think ARG pick up most of the cases.
Yes, sir. But then again, in the younger children, that's a challenge doing a ERG in some of them, because they would present at 3 months of age, 9. We can do it, sir, but then again, that's a little bit of a challenge, and it may not be very reliable also. But once you pick up these signs and you combine all of them, you can definitely make a diagnosis.
Nice.
So basically, what we do in our clinic is that patient has photophobia, like
Yes, sir.
we do an ERG and we do a UA and see the fundus and do the ERG. So that is how we
Absolutely
think that we catch most of them. But you are absolutely right, because if ERG is not there and if general anesthesia facilities are not there, then fundus is normal and it will keep on moving in the city.
Yes, sir.
So that is a good insight you have
Slowly
given
we are
there,
trying
Ripa.
to differentiate, because some of the cone rod dystrophies also may present like that.
Yeah.
This is pure cone dystrophy. But slowly we are seeing that the fundus findings and the autofluorescence findings are much wider in the cone rod cohort than in the cone dystrophy or achromatopsia, which is very limited to the foveal area rather than the posterior pole or till the arcade area.
Yeah. Thank you.
Thank you.
Thank you.